site surgery because of the impaired swelling and impaired circulation. Same thing if they have a mastectomy. You're going to have the lymph nodes filled, and so you can't do blood pressure. You can't put an IV in that arm. You're going to have swelling anyway. If possible, non-dominant hand. A lot of times, if they're a hard stick, we're just glad to get an IV, whatever arm we can use, whatever hand we can use. So if we have a choice, that's nice. We already talked about lower extremities, feet with kiddos, infants use a scalpel. Okay, calculation hourly rates. A lot of times we need to know the hourly rate. It's an easy formula. Total amount of fluids over the number of hours. Okay. Do know that on testing, at the end of the semester, this is just a reminder, we have a math test, 10 points like you did, 10 questions. Just like there was a math test in fundamentals, each semester you have it. You have to get at least 90%, you have to get 9 correct at least in order to, it's a high stakes test, you have to be successful. To help prepare you for that, on every med-surg test, it's not on psych test, on every med-surg test, expect a couple of math questions. So get it right. You don't want to miss out on the points. Plan to practice your math so that you can calculate it. In terms of test taking, if math becomes easy for you, do the math questions first. Through the last page, so you have to start on the front page. Get the math done and then take the test. It's up to you. Total amount of fluid over the number of hours, give you the mLs per hour. So a lot of times you need to know hourly rates. That's how we calculate it. Examples, get out a sheet of paper. Oh, that was the other thing I want to tell you. For testing, we provide the calculators. You cannot use your cell. You cannot bring your own calculator. We have calculators for you that we pass out through the Buck Special at Walmart. And that way you can't have your smartwatches on, those kind of things. So go ahead and calculate the hourly rates for all this. Okay, let's see what you get. There's 5 of them. about done? Okay, so how do I set up my first example? A liter of D5NS is to infuse over 8 hours. What's my hourly rate? How do I set it up? 1,000 over 8 equals 125 mLs per hour. Right. So and you'll get to where you know that if it's, we're going to run 3 liter bags a day, we have a 125 hourly rate. It'll become automatic. It isn't in the beginning, but it will get there. Okay, next one. A liter of Lr to infuse over 10 hours. How do I set it up? 1,000 over 10 equals 100 mLs per hour. Okay, same thing. Total amount over the amount of time. Let's do the next one. 500 over 10. So now it's not a full liter. What's the answer here? 50. Okay. We have a rule about tubing. Anytime we have an hourly rate less than 60, we use micro drip. In your IV, let's see. When we go into the lab, here's a drip tray. Boy, that doesn't even look right. You have a drip chamber. If it's a needle, that's called micro drip. If there's an open tube with a large drop, that's macro tubing. Macro versus micro. There's 60 drops per ml. With macro, there's 10, 15, or 20 drops per ml. So if it's 50, then we use the micro tubing. FYI. Okay, so we did the 500 bag. 250 of an IV antibiotic to run over 75 minutes. How do we set that up?
200.
So we're going to put, let's set it up here. How do I set it up? Use the same rule. So 250 over what? 1.25. 1 because it's an hour and it's 25% of another hour. 1.25 for 75 minutes. How much is that for my hourly rate? 200. Okay, let's do the last one. We have 100 IV piggyback to infuse over 30 minutes. How do we set that up? So I'm going to put 100. How do I designate 30 minutes? 0.5. What's my answer? 200. Those are just examples of how to calculate an hourly rate. Anytime you have a math question, what do you want to be sure and understand? What's the question asking me? Is it asking me drops per minute? Is it asking me the hourly rate? What's it asking me? Is it asking me both? Be very clear, because if we're only asking the hourly rate and you give us the drops per minute, you'll get it wrong. If we're asking the drops per minute and you only give us the hourly rate, it'll be wrong. Know the question. Ask yourself. But that's true on test questions in general. What do they want to know that I understand? What's this question asking me? We very carefully select and purposely put in questions to see, do you understand concepts? Okay. So those are just examples of hourly rates that we'll run across and you'll need to be able to use. So when it's 75 minutes, you know that that's going to be 1.25. When you know it's 30, it's going to be 0.5. Rounding rule, when we're giving meds, we round to the nearest hundredth. Hundredth, not tenth, hundredth. FYI, for testing purposes. With drops, we have to round to the nearest drop. Okay, for the drop partially. So if it's 5 or above, we round up. If it's below, we round down. The standard rounding. Okay. So hundredths. Here's an example for medication. Round to 2 places, hundredth. So example 1.226 would round to the hundredth. 10th, 100th, it'd be 1.23. For the IV drip rates, you round 5 and above to the nearest drop up or below. Okay, let's look at some vascular access device. Has anybody known someone with cancer that got chemo at home? Anybody know someone? They'll implant a port. That's your implanted ports. And they'll have to use a special needle to access the port for chemo. And so they're able to, instead of getting stuck every time they have chemo, they just access the port and then they'll give them their chemo treatments. So hemodialysis, they will have to go to surgery. You have to have what we call an AV shunt, arterial venous shunt, where they have access to your artery and to your veins. So they're going to pull out your blood, clean it, and put it back in. So know that there are various devices. This is just an IV. Now it's very large because we know that this is where we insert. It's a needle. We're going to pull it out. But this is actually about an inch. It's about an inch under the skin. Not very far. It's a short peripheral catheter. For our superficial veins, you want to be able to feel them. They need to be very superficial on top. And this IV can last, typically, it's 3 days. Otherwise, we start having infection rates. So that's why we have to, sometimes you have to start an IV because it's been 3 days, and they have a peripheral IV, and we have to change it so it doesn't, so we don't risk infection. They just do that. We can't use veins with mastectomy when they've had a breast removal. They pull the lymph nodes, and so there's no way to drain the arm. They have a lot of edema on that side, so that would be a problem. Anytime they remove the lymph, that's your travelers. Okay, so that's your drainage system, and so they pull that, and they've got a lot of lymphedema. Paralysis of the upper extremities because you have no innervation, so you have pooling. And then dialysis graft or fistula. CDC recommends a sepsis preparation. So hand hygiene, clip the hair, don't shave because that abrades the skin and can irritate it. Ensure the skin is clean, wear gloves. And we don't remove part of the glove so we can touch. That defeats the purpose of a sepsis. And then we need to use chlorhexidine or alcohol to prep to minimize infection risk. Central lines, those are put in by X-ray physicians, so hopefully you'll get to see it. They'll remove them in the room, and so sometimes you get to be there to watch that. And then always chest X-ray for confirmation. For the central lines, again, it runs from your antecubital space all the way up to your subclavian. So they're lengthy. And again, X-ray determines that. Okay, so here's a nice example. Look how long that catheter is internally. It goes into the antecubital space, and then it has to run all the way. It's a little black mark all the way to the subclavian. Some complications of a Picc line. Phlebitis. Now, what's a phleb mean? Real important to know your words. What's phleb mean? Vein. What's an itis? Inflammation, so inflamed vein. Okay. A thrombocylobitis. We've got an inflamed vein and a clot. Okay. We can have the catheter-related bloodstream infections. Infiltration, extravasation is rare in a Picc line, and it can occur with all kinds of therapy. So again, we want to do our flushes to keep our lines paid. A port, usually in the chest. Okay, it's not visible externally. We have to flush before and after. The catheter-related bloodstream infection. You can have hospital-acquired infections, and so just maintaining asepsis is really important. Do want you to remember, it's standard now to use pumps. We used to hang bags by gravity and tape them so we could track their hourly progression, but it's routine for IV piggybacks and for IV fluids to have everything on a pump. We're still accountable. We're still accountable for the rate of flow. And then there's a list of complications. Actually, I probably need to change that with the new text. I don't know that that's correct. Anybody got page numbers? Complications of IV therapy in your book. It's in chapter 15. What page? Anybody see the pages? I missed that. I tried to make sure the lab work was similar. What is this? What?
The same pages.
Oh, it is. Maybe I did check it. Okay. Oh, yes, because it's 15. It used to be chapter 13. Oh, I did. Okay, good. Okay, so local complications of IV therapy. We're going to look at complications now. There's two basic classifications. Localized, so I've got an IV in my hand or my forearm. So we're going to look at local complications, things that happen right here. Very different than systemic. What does systemic suggest? Body, head to toe. First figure out, is this a localized reaction? Or is this a systemic reaction? Anticipate test questions where you come into the room and the patient says something or you see something and you got to figure out what it is. Because that's what happens clinically. The patients don't say, I have infiltration. They say, my IV hurts. And then we have to go assess and look. So that's how I'm going to test you. We're going to have scenarios where you come across a patient, you see, hear something, and then you determine what this is and what you should do. Okay. So let's look at our localized reactions. The first one is infiltration. That's where the needle in my vessel gets dislodged. How does that happen?
Patient moves.
Well, maybe the IV side is right on my wrist and I'm doing this all day. Okay. Maybe I have a loop of tubing and I get it hooked on the doorknobs, or I get it hooked and it gets jerked around. Maybe the tape is loosened and no one's taken the time to tape it down securely so that it stays in the vessel. Those are a number of things. But it allows the needle or the cannula gets dislodged. And so now it pokes a hole in my vein. Indicators. Wherever my IV site is, localized edema. Why? Where's the fluid going? It's not going into my vessel. It's going into the interstitial space. It's poked a hole. The IV cannula has poked a hole, and so now fluid from the IV is leaking out around the space, and so I'm going to have localized edema. It should be in my vein. It's not. That is infiltration. It allows fluid to collect surrounding tissue, your interstitial space. So of course, we're going to have localized edema. It's not going to feel good. It's going to hurt. My IV is going to slow or stop because it's not adding fluid to my vessels, to my bloodstream. It's going into surrounding tissue. And then my temperature, my localized skin temperature is going to be cool. Why? Coming out of this. Why? Think about the fluid.
It's room temperature.
Do we heat up IVs before? No. They're a cooler temperature. Has anybody ever gotten an IV and gotten chilled? Yeah, because you've got that fluid going into your bloodstream, and it's a cooler temperature than your body. And so you get chilly. So it's collecting in around your vessel, so it will be a cooler temp. Okay. And then you may have a pallor, a blanching, a lighter shade at the IV site because of that. How to check. You can use a tourniquet to compress, and while you're there, we can check for tetany too. Get a toothbird. So you get a tourniquet, you check to see if the IV stops. Why would the IV stop? Because the fluid is running into the vein, and I compress the vein, and so my IV will stop. That says it's in the right spot. If I compress the vein and it continues to flow, that means it's going into the interstitial space. And it's a sign that you have edema, infiltration. If it was a bi-gravity IV, what could you do? This is how we used to check. We used to take the IV, we had a bi-gravity, and we'd lower the IV bag, lower their IV. What would happen?
Would it stop?
Wouldn't stop. If I lower the pressure, is fluid going to run into my vessel? No. What's going to happen? Blood is going to come out and go into the IV tubing. Now, do you have to have a whole tubing full of blood to figure out you're in the... No. It's like, okay, we saw blood. Freeze it up. You don't have to fill it with blood. We got it. So, the other thing we can do is aspirate at the nearest port to see if we have a blood return. But sometimes we don't. Sometimes we don't get a blood return. Okay. Infiltration, how to prevent it. That should be part of our sweep assessment when we come in. We should do head to toes. How's the IV running? Okay, how's the IV site? They got NG2. Oh, that's sucking. Oh, we've got an IV bag. That's still draining. Or Foley, that's still draining. We do that kind of head-to-toe assessment when we go in. We do our initial one, but when we work with them, we should have our eyes and ears open. We should still be looking at things. Oh my goodness, here this tube is kinked off. I don't wait till there's a problem, I unkink it. That's part of that general assessment we do every time we have contact with them. So I'm going to assess my site frequently. Maybe it was secure that morning and I come in and I notice it's kind of wobbly. Hey, let's take care of that right now. Get some tape, secure that. We don't want a problem. We want to prevent a problem. Watch for any loose tape or tubing loops. When those loops get too big, they're easy to hook and jerk it off. So, I tend to minimize the loops, have it securely taped. Treatment. If I do have infiltration, if I do have swelling, what do we do and why? DC the IV. Why? Help me out, Brenda. Why do we DC the IV? Because it's going to get worse and worse. The swelling's going to get worse and worse. Yes. Do I have anything I can plug that hole with? No. We're going to have to pull it out. Just restart an IV in a different spot. That's what we have to do. Okay. So I'm going to DC the IV. I'm going to elevate the arm. Why? Rob, why do we elevate the arm?
To prevent it from continuing to go up the vein.
We're just going to help with swelling. They've got some swelling. Elevate the swelling.
To let the blood.
Yeah. to help minimize. You don't want it dependent. You're going to get more swelling. You want to elevate the arm, minimize the swelling. It'll take care of itself. It'll start resolving itself. If it's significant, warm packs to increase circulation, reabsorb the fluid, and then restart the document. Do I have to, Bailey, call the doc and get another order to restart the IV? Why? What's your rationale?
Because we're not asking for like more IV fluids, we're just doing
We already have an order. My job is to maintain the IV. I've already got the order. I'm just continuing the order. Right. So you don't have to get contact. I might need to contact if it's really swollen. We did have a situation. This was when we had, it wasn't on a pump, it was by gravity. It was at Memorial Hospital. We had an elderly man. They hung a new IV bag at 6 a.m. We came on at 7, got a report. She went in and checked, and she said the IV's empty. It's like, oh, wait a minute, that's only an hour. We've got a liter of fluid in this elderly man in an hour. His arm, here to here, it's all gone in his arm. Pretty infiltrated. Okay. So, checking IVs, real important. That's very painful. And then you restart your document. It was very memorable. Extravasation. I've got IV meds, and they leak into surrounding tissues. They can be very corrosive. They can be very damaging to localized cells and tissue. And I would have some examples. That's when we talk about extravasation, that's the most common designation is medicines that I'm giving leak into surrounding tissues instead of me giving them and them being in the vein. Indicators. So we may have burning and pain. What level of burning and pain? People don't scream over infiltration. It doesn't feel good. It hurts. They'll complain of pain if they're conscious and aware. But you don't have people in severe pain over infiltration. You can have it over extravasation. The skin may be bruised. That means there's cellular death. So it's maybe discolored, bruised. The site may become dark due to tissue injury with severe pain. You may have paralysis, loss of sensation. That's a really big deal. Prevention. Good IV technique, frequent monitoring. Treatment. This has been a recent change. We want to stop the medicine immediately. If the medicine is going into surrounding tissue instead of going into the vein, we stop immediately. We leave the needle in place. Now, what in the heck could we possibly be thinking? We want to give an antidote. Okay? We leave the needle there. We want to try and aspirate the material. And then we're going to try and give an antidote. So that's why we leave the needle in place. Slowly aspirate as much med as possible. Do not apply pressure to the area. Remove the IV access while aspirating. Notify the physician. We're looking for an antidote. Elevate, initiate measures. Here's an example of extravasation. Significant tissue damage from a med going out of the vein and into surrounding interstitial tissue. Here's another example. Now, I got you the icky pictures to make an impression. Okay. Here's another one. I think that was Levithed. That was good. Here's another one that's healed up. Significant. Okay. That's an example of extravasation. So we always need to know we're in the vessel. Another localized problem. So we covered infiltration, localized swelling, IV fluid running into surrounding area. Then we covered extravasation. That's when our med, corrosive med, is going into surrounding tissue, killing tissue. Now we have thrombosis. So we got a clot. It's a clot in the IV because the rate of flow has slowed down. I've come into a room and seen the IV stopped. And they're still on IVs. It's like, who in the heck stopped this? because we're going to have a clot. Or if it's too slowed down, it can form a clot. May occur when the patient bends their arm. Okay? So they have an IV, they bend their arm, they impair circulation, it gives us a risk for a clot. They have to be reminded. Normal clotting time, 6 to 8 minutes. So if we're going to change an IV bag, can you change an IV bag while the IV is infusing? No, you can't. We have to pause or turn the IV off. But how much time do you have? Okay, so don't go to lunch. Have your new IV bag ready. You put it on pause, take it down. Good. Doesn't take 6 to 8 minutes. We're with you. Okay. Thrombosis. Let's say we have a sluggish IV flow or stoppage. Prevention. That's why. Now we can lock it off. If they don't need fluid replacement, we can just lock it off. Okay. Otherwise, we run it at a 2 keep open, keep vein. We run it at a fast enough rate, a keep vein open, 2 keep open, to maintain a rate of flow. Our machines, often we'd have to run it at 40 an hour. That's not much. How much is 40 an hour? You know those little cups, medicine cups? How much is in a little medicine cup? Yeah, 30. That's like getting that much every hour. It isn't much. But 40 will keep it open, keep it patent. Or if we lock it off, if they don't need any fluid replacement. We flush every shift. Treatment. We have a clot, we try and aspirate it. We do not irrigate. Why do we do not irrigate a clot in an IV? It will travel, if it lands in the brain, it causes a stroke, pulmonary emboli, if it lands in the lung, big deal. We don't irrigate. And then, so if we have a clot and it's not running, it's the same thing as the infiltration. We're going to DC it, we're going to record it, we're going to start a new site. Okay. Thrombocylobitis. Again, we're all just talking about localized responses where the IV is. Wherever the IV is, it's a localized response. Now we have a clot and we have an inflamed vessel caused by irritation, trauma to the vein. Potassium in particular is irritating to veins, and so we can wind up with some of that, a phlebitis. Phlebitis is, with a phlebitis, we always have the itis symptoms. Pain, redness. Okay. You will see tracking of redness up the vessel. It will be irritated. So there's a redness, pain, warmth because it's inflamed. Warmth. We're not talking about infiltration with cool fluid now. Swelling along the affected vein, sluggish flow, possible fever, increased pulse. Prevention. We need larger vessels for irritating meds. Change our IVs, our saline locks, or IV sites every 72 hours. Make sure it's secured. If we have thrombophlebitis, an inflamed vessel with a clot, we're going to remove the IV, we're going to elevate the site, cold and warm compresses alternated. Again, we don't rub because of what? We could dislodge the clot, put it in the general circulation. They could wind up with stroke, where clot gets into a vessel, or with pulmonary emboli. Okay. So those are localized. We also have ecchymosis, hematoma. Anybody heard a nurse say blowing a vessel? Okay. Blowing a vessel is when we're starting an IV. We can't see down into their vein. And so it's like, it's running your needle. Here's your needle. You run it all the way through. We puncture it, so it pops up really quick. We have a little puff of blood in there. That's blowing a vessel. That's a hematoma. What do? Pull the needle out, put a Band-Aid. We won't go back there. Move up the arm. Okay. We can have a localized infection. once we used to use 2x2 gauze and tape to secure it. When we went to the first type was off-site years ago, where it was an occlusive dressing. I'm telling you, the infection rates dropped like a rocket, really. So we don't have near as much with those occlusive, clear dressings. The old 2x2s were awful. We'd have pus and it'd be sticky and dry and stick to the IV. You can have nerve damage too. This is called blowing a vein, the ecchymosis hematoma. We've already talked about that. Infection, localized inflammatory response, porous sepsis. Don't be coughing on your IV sites. Don't be licking your fingers and touching the patient. Okay. Keep the gloves on. Don't be taking parts of the glove off. Or not changing your IV site. It has to be changed every 72 hours. Okay, infection. We got the swelling, pain, discharge. What's that called? Pus. Yeah, it's pus. It's infected. Redness, pain, swelling. Prevention, go to sepsis. Change your dressings and tubing every 72 hours. A lot of times, for patients coming in 72 hours, we used to have little tabs of when to change the IVs. That was a pain in the butt trying to track that. Well, Johnny came in Monday, but Susie came in Tuesday, so we can get an extra day. They started what really helped was when they started changing. Everybody gets an IV tubing change and IV change on Wednesdays and Sundays. And then we know that we're good with our parameter. So I'm not sure what that is for St. Mary's, how often they do that. We used Wednesdays and Sundays at the university. Everybody gets new tubing. Even if they came in the day before, it doesn't matter. It keeps them on a schedule, and then we can prevent infection. If you get an infection, we DC the IV, should be cultured in the site. Interventions are to reduce infection rate. You need the needleless system, don't tape connections, and then hand hygiene. Okay, questions about localized. Has anybody ever seen infiltration, thrombophlebitis? You're nodding your head, Caitlin. What have you seen?
Well, I've been a phlebotomist for years. So
You're a phlebotomist?
Yes.
So what is that? What is a phlebotomist? They draw blood.
But I caught infiltration my first semester.
Oh, good for you. What did it look like?
So she was complaining of it was hurting her hands.
And where was the IV?
In her hands.
On the back side of her.
On the back side of her hand. She was complaining about it. I was like, well, let me take a look. Because I had seen infiltration before and I touched it. It was warm and red. I said, let me go grab the nurse.
Okay, now that's going to be more than infiltration. If it's red and warm, what do we actually have? An itis, right?
But it was swelling too.
Right. And so she could have had a thrombophlebitis. Because typically with infiltration, there is not redness. But there is swelling. And it typically is cool. Okay? So I suspect it was a combo.
Right.
If you've got warmth and redness, you've got an infectious process.
But she also kept doing this. She kept running. So I was wondering if some of the redness.
Okay, yeah, now we've got another factor that's involved. Yeah, if you're doing this, right. Anybody else seen thrombophlebitis, phlebitis? Ever seen the pink tracking up a vessel? Very distinct. That's your phlebitis. Anybody seen an infiltration? Had a family member infiltrated? Okay. Okay, now we're going to look at systemic complications. These aren't just, we talked about the localized. What happens at the IV site? Now we're going to talk about getting an IV, and I can have something that affects my whole body. So we're going to look at circulatory overload, speed shock, allergic reaction, and a catheter emboli. Circulatory overload, so too much fluid too fast. Who would be at risk? Elders? Okay, who else? Did you say heart disease? Heart disease, elders are all at risk for too much fluid too fast. I have a pump that doesn't work well, my heart. I've got history of heart disease. Or I'm an elder, and so when I taught geriatrics, gerontology, one of the things that I realized is I call it the 3 Ds of aging. Dry up, droop, drop, every system. Everything shrinks, doesn't work as well, gets drier, hangs where it shouldn't hang, all kinds of stuff. Okay. So, circulatory overload means I've got too much fluid too fast. Indicators. Folks, when we have too much fluid, it starts backing up and then starts infiltrating our lungs. Dyspnea. I am having difficulty breathing. A cough. Rales. So now I've got fluid collecting in the lungs because I've got too much fluid on board. So, of course, my pressure and pulse are going to go up because my blood volume has expanded. I'm hypervolemic. I have shortness of breath because fluid is collecting in my lungs, so my alveoli cannot do the CO2-O2 exchange. I have neck vein distension. You can see the increase in volume because, again, I'm having too much fluid in my vessels, and it's also affecting the distension. Prevention. Carefully monitor the IV. Check a cardiac history. You need to be attentive. If they've had cardiac disease, this might be too much too fast for them. I need to be monitoring them. And then watch their ionosphores. Treatment. Do we want to get rid of the IV? Help me out, Peyton. Why? Speak up just a little bit.
And you're still going to have to give them medicine.
We're going to have to give them medicines. There's nothing wrong with their IV site. They have too much fluid. We're going to have to give them some medicine to help them get rid of it. So I want to keep my IV. Nothing wrong with the IV. It's the amount of fluid we've been running. Or it's the ineffective pump. Or both. So, but I am going to saline lock it off. You don't need any more fluid running through. So I can automatically, as a nurse, convert an existing IV to what we call a saline lock. Why would I raise the head of the bed? Help me out, Brenda. Look at your human being. What are the symptoms? Look at your human being, the indicators. What are your symptoms? Why do we raise the head of the bed? Dyspnea, which means what? Trouble breathing. And what else do they have? And why do they have a cough? Because there's fluid in the lung. And they can't have alveoli get CO2 exchange. There's fluid interfering with that. So they have an automatic cough. Rales, that's your lung sounds. Okay. So now why are they raising the head of the bed? Expand the lungs and breathe. You're going to see orthopnea. They're already sitting. You can't breathe. You already sit up. Expand those lungs. That's why we raise the head of the bed. Good. We always have to look at the human being. Always. That's the first thing. What's going on with this person? Give O2. Michaela, why are we giving O2? Because they're having dyspnea, short of breath. They have fluid filling their lungs. Their O2 sat's going to drop. Vital signs. Why are we doing that? They are becoming more unstable. We need to check and see what's going on. That's exactly right. Or vital signs or pulse ox. Okay. And then contact the MD with this data. Like so. I would anticipate what? That kind of picture, dyspnea, short of breath, they weren't before. I would anticipate what? Think about what the problem is. Why are they in this fix? They have too much fluid. I would anticipate that they're going to give me a mag to get rid of the fluid because that's the problem. Right? That's why I maintain that IV site and anticipating that. Okay? The other thing, too, is when we call the doc, what set of vital signs should we have just gotten? The current blood pressure. We don't go for an hour and then call them up with the previous data. We have a fresh set on top of our others. And we give the situation. This is Mrs. Smith with fluoride. She's here for current situation. We've got this. Go prepared when you talk to the doc. You have all of your data lined up. Don't go, don't coach it with the phone. Okay. So we anticipate hydrochlorothiazide, a Lasix diuretic to get rid of that. That's what we're going to have to monitor them, keep them on O2. Okay. Questions about that? Some other complications we see, speed shock, rapid infusion of meds or bolus, where we have a toxic level of med. That's where we're, with circulatory overload, we're giving too much fluid. Speed shock is when we give the med too fast. An example of that would be like vancomycin, running it too fast, red vein syndrome, cardiac arrest. We can go our whole lives and take Tylenol or ibuprofen, and tomorrow develop an allergic response. So those things can always happen. We check our allergies, but do know that can happen. Catheter emboli, that's where whenever we remove a catheter, we want to make sure, you line up with the IV. If we have our IV this way, we don't go at a 45 angle. You line it up with your vessel, and then you remove it so that it comes out in one piece. We don't want that part of the catheter to be an emboli or a foreign body in the vessel. Okay, air emboli. Another example of a systemic reaction. It's a bolus of air that can block a vessel, resulting in cellular death. That's where we have a decreased pressure and pulse, loss of consciousness, cyanosis. That's why what do we call it when we fill our tubing? We fill our tubing. Mazza, what's that called? Priming. Priming. Prime our tubings. We prime everything. We're always filling it with fluid so that we're not running air. If I have IV tubing and I don't prime it, I don't fill it with IV fluids, what's going to be running into the vessel? Air. That can become an emboli. Okay, a stroke, pulmonary emboli, big deal. So we prime everything. Occasionally I've had students who've gone to this area or that area and they'll say, this person didn't prime, and it's like, it's very risky. And then and they've sometimes asked me, how much air does it take? It's like, can't you see the research on that? Who wants to be the group that we are going to experiment with? Well, let's try 30 mLs of air and see if you have a bolus and a heart attack. Well, let's try 60 with you. Let's see who gets the stroke. I mean, that's just bad news. So, we prime everything. You fill your chambers. You don't go to the bedside with an empty syringe. I always put an ml, just an ml in my syringe so that I'm not working around with an IV with an empty chamber. I just don't like that. Okay, so we're going to prime tubings before we hang our IVs. And then we change your IV bag before it gets totally empty. That's one of the sweeps. When I'm taking care of a patient, in and out, I should be checking my IV bag. How much fluid do I have? If it's 100 an hour, and they only have just a little bit in the bag, what does that tell me I should do as a nurse? What does that tell me, Hallie, that I should do as a nurse?
If you only have a little bit left there.
Let's say I have 200 in the bag. They're running at 100 an hour. What should I be doing?
About the
Well, I can wait till I get to 100, but couldn't I go get my next IV bag and put it on the pole? You'll see nurses do that. It's called anticipatory planning. I see that my IV is getting low-ish. It's not like we have to refrigerate them. And I go, put the bag, so it's right there. So in the next several trips, it's like, whoops, okay, time to change my IV bag. We have had to run down the hall, but I don't like it. How can a student buy more time? If you look up and go, holy crap, I got 50 mLs left in the bag, and it's running at 100 an hour, I screwed up. I should have already been talking to my instructor a couple of hours ago that my IV bag's getting low. What could you do to buy time? What? Pause it. Well, that means that I stop the rate of flow, and what's my risk? A clot. So, good try. Help her out. I could reprogram the IV pump. What could I do? Okay, we're running at 100 an hour. I've got 50 left in the IV bag. What can I program it to? If I program it to 50, I've got how much time? I've got an hour. It doesn't take me an hour to go get an IV. Did you see how that little intervention buys you some time? Yeah, a very practical little intervention can buy you some time. In a pinch. And then what do you do the next time so you don't get in that situation? What do you do the next time so you don't get in that situation? Nadia. You track your rate of flow. You kind of give an estimate of when it's going to be running out. If it's going to be running out at noon and you're wanting to go to lunch, you got to do some anticipatory planning. It's not like we can be down at the lunch table, oh my, the IV ran out. Gee, I'll fix that when I get up there. No. You adjust your lunch or you adjust the IV. You don't slow it down, you go ahead and change it. Okay. Those are some practicalities that happen. That's our job, maintain the rate of flow. You get busy with stuff and I'll be dang. That got away from me. That's something on your planning sheet. A lot of times it's very helpful to have a schedule for yourself. Sometimes I make students that have trouble managing their time, I make them. You have to show up at clinical with an hourly activity. 7 o'clock, what are you doing? List your tasks. 8, 9, 10, 11, 12. Some of those should be wins by check my IVs. When am I going to do my vital signs? When am I going to chart? When am I going to gather data? When am I going to walk the patient? When am I going to bathe the patient? Okay, now we're going to look at air emboli. We've got a bunch of air, got in this patient. I should lower the head of the bed, turn them onto their left side. This allows the air emboli to be trapped into the right side of the heart, to pass into the lungs, into the pulmonary system. We give O2, they need prompt medical attention. I don't see this clinically much because we prime everything. Okay, older adult care, skin care, vein and catheter selection, cardiac and renal changes. Okay, just know with elders, they've lost the collagen. It can be papery, it can be thin. When you get older, you don't have cuts anymore. You have skin tears. I remember my first skin tear. It was not a happy thing. It was like, oh my gosh, I didn't get a cut. I got a skin tear. Oh no. A sign of aging. Ladies and gentlemen, you'll have your turn. It's true. But I don't know how seniors deny their age because there's so many signs right there. You know, skin tear. I was working on the farm and I was working with fencing, and I would have said cut myself, but I looked down, it's like, yeah, that ain't a cut, that's a skin tear. Okay, vein and catheter selection, they're rolled, there's not a lot of padding. That's just part of the aging process that makes it more difficult. And what do we know about aging and cardiac and renal? changes. What happens? It diminishes. Drive, droop, drop. Kidneys hard. So it just can't tolerate what adults, middle-aged adults or young adults can tolerate in terms of fluid, in terms of medicines. A lot of times if you see a gerontologist, they very careful with their dosages. Dosages of meds have to be reduced because the liver doesn't detox, break it down. Kidneys don't excrete it as well. Just every system, it diminishes. Okay, we're going to do some I'll tell you what, when we take a break, we'll come back to calculations. We've got a couple of potassium, magnesium calculations. Did anybody go to McDonald's for lunch? It was cash only today. But someone else was telling me that I think Madison's, their debit charge cards were down too. I'm not sure what's going on. I carry cash, so